Thank you so much for joining us. Welcome to the Industry Spotlight webinar, Ultrasensitive MRD Testing for Post-Surgical Management in Non-Small Cell Lung Cancer, sponsored by Natera. I would like to welcome Dr. Linda Martin, our moderator for this evening. Dr. Martin, let me pass it to you.
Thank you, Karen, and thank you all for joining us on a Thursday evening. I'm really looking forward to our discussion tonight. I am joined tonight by Dr. Leo Tapias from University Hospitals in Cleveland and Dr. Michael Krainock, who is the Oncology Medical Director at Natera. And Dr. Krainock's going to start things off in 1 minute. We're going to move to the agenda real quick, and then he is going to take it from there. So the topics we're going to go over tonight are unmet needs in resectable non-small cell lung cancer and use cases for what's called MRD or molecular residual disease testing in non-small cell lung cancer, data for the use of Signatera assays in lung cancer, some real-world cases that will be presented by Dr. Tapias, and then we'll leave the forum open for question and answer and to talk a little bit back and forth amongst the panel about future direction. So I'll hand it on over to Dr. Krainock.
Thanks, Dr. Martin. Thanks, everybody, for coming. As Dr. Martin said, I'm Mike Krainock, one of the medical directors here at Natera. So these are kind of the clinical utility buckets we think about using Signatera in the setting of non-small cell lung cancer. In patients who have been definitively managed locally, can we use testing to better inform adjuvant treatment decisions? Whether that's adjuvant chemoimmunotherapy, whether that's an adjuvant phase of a perioperative approach to systemic therapy, whether that's continuation of targeted therapies beyond kind of time-gated prescribed lengths of treatment. Can we add value to those types of decisions for providers and patients? And then in the surveillance setting, is there value to doing molecular monitoring with Signatera alongside standard of care imaging? So can we tell you ahead of time that disease is brewing in a patient? Can we identify that before you can see it on a scan? And is there value to that? Can we change the cadence of scanning such that we identify overt disease sooner when it's more manageable? Can we even use that as a signal to treat in the future? So is there value to doing this testing alongside CT scans and PET scans, for example? And then in the metastatic setting, when we know disease is present, can we add value to regimen selection for patients? So, we start a patient on a prescribed regimen, we see progressive disease, and we go to the second line. Unfortunately, we know those patients typically don't have a very good outcome. Can we add value to that group of patients by letting you know sooner that a prescribed regimen is not going to result in durable progression-free survival or acceptable overall survival, for example? And can we use that signal on therapy as a switch to escalate treatment or change regimens? And does that provide clinical outcome benefit for the patients? So these are the kind of the areas broadly where we think about deploying this technology in the context of non-small cell lung cancer. So what is ctDNA? So we've known since, I think, 1948 that nucleic acid floats freely in our blood, and it's not confined to cells. In the 1970s, it was observed that patients with cancer have more cell-free DNA. And it wasn't until the 1990s, actually, that it was definitively shown that that's because there was a fraction of cell-free DNA coming from the cancer. So we all have physiologic cell-free DNA in us all the time. The levels change based on our activity. If we go for a run, if we lift weights, if we have surgery, our physiologic background cell-free DNA will go up. But another reason for it to go up is that there's a foreign producer of DNA in the body, and that's a tumor. And in the 90s, we learned how to kind of exploit that fact by picking out those tumor-associated molecules preferentially in that background of cell-free DNA. And that's what we call ctDNA, or circulating tumor DNA. Our approach is tissue-informed, which just means we start with a piece of the cancer. That could be from a resection specimen, could be from a core needle biopsy. We've designed successfully from EBUS FNAs. Once we have the cancer, we will extract the cancer's genome and we will sequence the cancer. At the same time, we'll sequence non-cancer genome from the patient that we usually get from buff coat. and then we'll compare those two sequences and we'll pick single nucleotide variants that are unique to the patient's tumor. So this is truly tumor informed. It's not just patient informed. I use the example that if you have, two concurrent solid tumors in a patient, they could be touching one another. As long as they came from a different ancestor cell, their Signatera results will be differently, and you can track them independently. Some of you who order may be ordering on multiple primary patients and will know that is something that we do. We only need the tissue that one time. So every assay time point is a simple blood draw. We receive the blood, spin out the plasma, extract the cell-free DNA from the plasma, and then we run our primers against the plasma to look for the single nucleotide variants that we've identified from the solid tumor that we sequenced. The report that you get is a quantitative report and demonstrates essentially change over time. The only normal value is 0. You heard me mention single nucleotide variants. So these are passengers. They're clonal. We expect them to be present no matter how heterogeneous a tumor becomes over time. But this is not a driver panel, right? So this isn't going to give you your EGFR, your ALK, your ROS mutations that you have approved therapies for. We have another test for that, though. That's called Altera. So Altera is our CGP, Comprehensive Genomic Profiling NGS assay, and Signatera is our passenger panel used for MRD and longitudinal ctDNA analysis. The nice part is of course, especially in non-small cell lung cancer, tissue is frequently the issue. We have to do so much with this tissue, and we're getting diagnosis based on less and less tissue all the time. We can offer both of those tests from the same sample tissue that you give us. So you can give us one sample of tissue, we'll give you back 2 tests. So one will be Altera. That's going to have your targets on it that have approved therapies. That's going to match patients to clinical trials. It's based off of a DNA and RNA, DNA whole exome and RNA transcriptome. We also can do PD-L1 and HER2 IHC. So you can get a lot of the things that you need from a CGP from our Altera test, and at the same time, we'll design you the Signatera test. All of that stuff is tissue informed. We are working on tissue-free options. So the Latitude test is now available for CRC. We expect it to be available for non-small cell lung cancer in 2026. As I said, tissue is frequently the issue. We understand there will be patients who simply do not have tissue, and we're working hard for solutions for those patients. The data in CRC is very promising so far. We expect the same in non-small cell lung cancer. This would be a test that you don't need tissue input for when it's not available. So that's Latitude, and that'll be launching for lung cancer likely in the next year.
Dr. Krainock, I'm going to stop you for a second.
Yes, Dr. Martin.
First of all, I wanted to bring everyone's attention to the fact that in your Zoom window, there's a Q&A box. And so if you have questions along the way, please type them in because we'll have time for question and answer at the end. And there may be an opportunity for us to answer some of those questions during the presentation. So please use that instead of the chat box as one option. And then I just wanted to check again on this Latitude compared to, say, a tumor informed, because I think that's a big difference that people maybe kind of miss sometimes because we talk about liquid biopsy and all these other terms out there.
Yep.
So let's say someone just has a suspicious looking mass on their chest X-ray or CT scan, and you haven't been able to arrange a biopsy yet, or it's a recurrence and you're not sure what's going on, or someone who has a concerning history. And essentially, you just have suspicious imaging. Is that where that Latitude assay would come into play potentially?
Yeah, potentially in those scenarios or scenarios where you have a known diagnosis of cancer, but you've exhausted all the tissue. So those will be scenarios where, we just simply can't get any cancer input for sequencing, so we'll have to do something tissue-free. So anytime that you have, a lack of tissue, we would plug in Latitude for that use case. I think what I would say is if you have tissue, use it. And if you don't, then, we'll have a good tissue-free option for you.
And also if you can clarify for the audience what CRC means.
Oh, colorectal cancer.
Okay, thank you.
Yeah, sorry.
Mike, it would be important also to mention for the pre-op biopsies, do we need to get FNAs, core biopsies? How much tissue do you need to generate a test? I think that's an usual question that we get.
Yeah, the more input, the better, Dr. Tapias. So, for instance, untreated resected non-small cell lung cancer, that will have a design success rate of, nearly 100%, say. Core needle biopsies will depend on the number of passes you're able to give us and the cellularity of the tumor. Very similar to EBUS FNA. Some FNAs, you've got a single pass and a few adenocarcinoma cells to make your diagnosis. So we will try to design on any tissue you can provide us. Success rates will be proportional to the amount of cancer you can get us, essentially. Ideally, if you have resected specimens, we ask for 5 to 10 micrometer sections of paraffin block as input. But if you don't have that, we will definitely still attempt to design the assay. And we've seen a lot of success from core needle biopsies and even FNAs. But I would say it goes in that order for success. Resected specimen, multi-pass cores greater than single pass cores greater than FNAs.
Great. Okay, sorry to interrupt. We'll let you
No.
continue.
Good questions. So coverage. So those of you that follow the field will know that we do have beneficial Medicare coverage decisions that are relevant to non-small cell lung cancer. One is specific to non-small cell lung cancer. That's for stage 1 through 3 surveillance. And then we have a really great broad coverage for any patient on immunotherapy. So that could be in the neoadjuvant setting, could be in the adjuvant setting, can be in the metastatic setting. It could be monotherapy. It could be, given among other lines of therapy. As long as the patient's on immunotherapy, will get reimbursed by Medicare. I do want to note, though, that we don't balance bill patients. So this is something that comes up a lot. So in other words, if your lung cancer patient, or really any patient with cancer that you're taking care of, you and the patient want to pursue testing, and they're not in a Medicare coverage bucket, or maybe they're privately insured, that really shouldn't be a roadblock to testing, because we don't balance bill. So what that means is if we ask for payment from the patient's payer, that payer declines to reimburse the test, we don't send the bill then to the patient. So there's really no financial toxicity to getting this test. The only time a patient would get a bill would be if they had private insurance and their payer did decide to cover the test and they had a copay or a co-insurance. That has happened when payers have decided to reimburse. If that dollar amount of that copay or co-insurance is too high, we have a financial assistance program for that as well. So I think the Medicare coverages are great for the test credibility, for the test adoption, to pave the way for broad reimbursement from private payers in the future and all those things. But I don't think you need to limit your ordering to just where we have Medicare coverage today.
And just to clarify on that too, Dr. Krainock, I recently heard that it's sort of like a one-time fee. So if, say, you were to get the assay at the time of diagnosis, that you can, as the clinician, you can ask for repeat assays as much as you want. You could do it monthly, you could do it once a year, but there's a one-time charge, and then it's sort of like as much as you want to order it, you can order it, and it doesn't continue to charge the patient or generate expense.
Yeah, we essentially have, approval for reimbursement based on a diagnosis and then some number of tests after that diagnosis. So we kind of get paid as a package or a bundle. And if you're interested in ordering the test in, your practice, then, one of our clinical oncology specialists can kind of go through the specifics of, what's included in each bundle and each package. But yes, we get like a basket of tests for one reimbursement.
Great.
So we account for over 90% of peer-reviewed clinical publications from commercially available MRD assays. We have over 125 peer-reviewed publications now. We've actually presented data from over 40,000 patients across 30 different tumor types. As you guys can imagine, these bullets change every time I give this talk. So, we have more peer-reviewed publications month over month. We have more adoption month over month. Now over 50% of U.S. oncologists are actually using the tests, and that equates to testing in the commercial setting on over 300,000 patients. So it's pretty remarkable. And with that comes a lot of real-world experience in terms of logistics and results delivery. We have a robust, very effective commercial team. They're very supportive, very knowledgeable, and they're really great partners for providers and patients in terms of their molecular testing. So over 90% of initial Signatera reports are provided within 3 weeks, and then 90% of subsequent reports are reported within 1 week. And that's, again, for tissue-informed testing. So pretty quick turnaround times. As I noted already, the Medicare coverages are also rolling in. So we started with colorectal cancer. We have neoadjuvant, adjuvant breast cancer, muscle-invasive bladder cancer, ovarian cancer, non-small cell lung cancer in the stage 1 through 3 surveillance, and then that pan-tumor IO monitoring decision that I mentioned, with more to come every year. So we'll talk a little bit about some clinical utility before I hand it off to Dr. Tapias for some data. I'm actually going to move into bladder cancer real quick, and I know this is a lung cancer talk, but this really illustrates the point really well. And we just published this data in the New England Journal and presented this at ESMO. This is, essentially groundbreaking data in this space. So we're all very excited about it. So I thought I would share it to illustrate the power of this testing and kind of, what we're talking about. So you're looking at the results of IMvigor11. Before I go through IMvigor11, just a few words on IMvigor10. So IMvigor10 was a study looking at atezolizumab in completely resected muscle-invasive bladder cancer. They were testing atezolizumab after radical cystectomy. And the readout initially from IMvigor10 was actually negative. So it did not appear that adjuvant atezolizumab improved recurrence-free overall survival in completely resected muscle-invasive bladder cancer. However, retrospectively, we analyzed a post-cystectomy time point in resected patients, and what we found is that there actually was a group of patients within IMvigor10 who did benefit from adjuvant atezo, and that was the group of patients who were ctDNA positive by Signatera. And so if you were ctDNA negative after radical cystectomy, and you look at those curves, not only did you not benefit, you actually kind of trended towards a worse outcome with atezo. But if you were ctDNA positive, there was a clear statistically significant improvement in your outcomes with the study drug. And so that was the first time this type of technology had taken a large pharmaceutical study and kind of turned it from completely negative to potentially positive for a group of patients. But of course, it had to be followed up with a prospective study, and then that was IMvigor11. So with IMvigor11, same group of patients. We looked at patients after radical cystectomy. We randomized patients who were positive to atezolizumab versus placebo, and you can see the results here. So the lighter blue line on top is the atezo-treated group, and then the dark blue line is the placebo group, and you can see that it was a 2-to-1 randomization, so there's more patients in the atezo group. But you see, look at the overall survival results here, 15% better at a year, and then 46.9% versus 62.8% at about 25 months. So meaningful, significant differences in overall survival using MRD guidance for adjuvant atezo. We didn't randomize the negative patients because, as I said, they tended to do poorly with drug in IMvigor10. We did follow those patients, and you can see if you're ctDNA negative, look at that overall survival. Those patients, 100% of these patients are alive at 1 year, and 97% of patients are alive at 24 months in the face of a very aggressive disease. So, I take from this, we could really benefit our patients by getting them to 0.00 on Signatera. We could, if we're not at 0.00, we're at risk, right? And if you can get the patient to 0, you've done them a real service. And so that's kind of how we think about, angling this test in clinical utility use cases is how can we help get more patients down to 0? Because it's a super powerful result for the patient with durable survival benefit. Very applicable to non-small cell lung cancer. We all know, as being close to this disease, recurrence rates are high. We've just kind of highlighted that here, but for this group, we all know this. You can see that even super early stage disease, you've got, over 25% of patients recurring even with stage 1A3 disease. Some of your 1Bs may be hitting 4 centimeters now and getting perioperative, but that's very variable across the country, of course. So there may exist many patients who undergo index resection as definitive therapy, where we could maybe inform, for example, adjuvant treatment decision-making for systemic chemoimmunotherapy, or we could inform consolidation decision-making in patients who are following Checkmate 816 or something like that. So very, similar diseases, I think, in many ways between muscle-invasive bladder cancer and non-small cell lung cancer, and where we think we could kind of add value to the management and decision-making in those patients. I kind of just said everything that I would say on this slide. This is just kind of a graphical representation with actually a few additions. But thinking about kind of the course of a patient who we're going to manage with surgery, we know many of those patients are getting neoadjuvant chemoimmunotherapy. Some patients are going directly to surgery. Can we better inform risk adjudication post-operatively and inform treatment decision makings, whether that's a go, no go, or whether that's extended therapy, for example? One of the things I think a lot about in terms of extended therapy is resected patients with drivers that are targeted and reaching the end of some prescribed time of adjuvant targeted therapy. We've seen data that suggests that when you take a patient who's had, say, 2 to 3 years of DFS on a really well-tolerated oral medication, when you withdraw that medication, there'll be a group of patients who are found to then be ctDNA positive in surveillance, and those patients will then recur, right? So, we've got a drug that's highly efficacious. We've already gotten 2 to 3 years of disease-free survival. Maybe just put it back on, right? Or use the test to screen taking it off in the first place. Something like that, I think is very safe and very appealing to patients and providers, and something that we'll study in the future as well. All right. All that being said, we have some data now and some cool cases, so I'll pass it off to Dr. Tapias.
Thank you, Dr. Krainock. I think for us it was very important to try to realize where this new information could fit in the timeline that Dr. Krainock just showed us, right? We took these patients for surgery or for neoadjuvant therapy followed by a resection. And with our timeline, everything was kind of like imperfect, right? We were following with imaging and observation for the patients that were not going for adjuvant therapy. And we were hoping that there was no actual imaging that could show some recurrence on these patients. It was quite imperfect. And we wanted to understand how the ctDNA would fit in that timeline of follow-up of these patients in terms of helping us identify patients that recur earlier or patients that were not going to recur and they were going to be okay and give an extra layer of safety. So what we did with these cases is we started to understand the ctDNA and we started testing on those patients. Some of them fell into those first 26 weeks after resection, and some of them were after that. We wanted to understand what happens with this patient that has been out of surgery for a couple of years, that this CT scan has not shown anything. And we're able to recruit about 108 patients that qualify for this. 69 of those patients actually were in that 26 weeks after curative surgery. All these patients were stage 1 and stage 2. We found that on the MRD window, about 4 of them were positive for ctDNA. And of all the patients, no matter what the time was, 12 of them were positive. What we wanted to see is how predictive that could be on top of following these patients with imaging with the CT scans every 3 to 6 months. And we saw that when we certified the patients during the MRD window for all stages, there was definitely a benefit in terms of those patients that were negative remaining recurrence-free survival. These patients were not recurring over time when we followed with these two things. And we saw that the patients that were positive, there was a big gap, and it was not only statistically significant, but clinically significant. We saw that for all those patients, including the ones who were stage 1 and all stages, the timeline for them changed. Instead of, hey, we're going to wait for another 6 months to get another CT scan, we're more proactively trying to find where that recurrence was. Was that lymph node that was borderline? Was that lung nodule that was sub 8 millimeters? And that prompted a change in plan, either getting a PET scan earlier or trying to obtain a biopsy earlier.
Dr. Tapias, can I ask you a quick question?
Totally.
And this could be for Dr. Krainock too. Is there any difference in the ability for this assay to detect recurrence based on the body part? Like, does it matter if it's lymph nodes or intrathoracic versus central nervous system recurrence? Is there any difference in the sensitivity or ability to pick up recurrence?
Yeah, so in our experience with this study, we saw that any extracranial recurrence was picked up by the assay. We had two patients actually that had a recurrence in central nervous system that were still signature negative, and yet they recurred. Changes in mental status, imaging that prompted to do that. So I think the caveat there is that I don't know if Dr. Krainock has any other data from other.
Yeah, I would agree. We saw that in this cohort. I think what we think is that an intact blood-brain barrier makes it harder for us to pick up signal because there's less circulating. Now, we don't miss all of them, right? It is hematogenous spread, right? So it's reasonable to think there's probably DNA out there in the blood. But the active shed that metastatic foci in the brain is doing is not making its way to peripheral circulation because of size and charge imbalance or incompatibilities with the blood-brain barrier. That's the thought. Um, we're working on some things that may make that less of an issue in the future. That will drive LOD down, limit of detection down, and we think that that will be less of an issue in the future. But yes, I would say that in terms of anatomic location and test performance, intact blood-brain barrier, CNS only metastasis would be an area where we would miss more than other places.
Great.
All right. Going back to the same experience that we had. Basically, this was very helpful trying to identify those patients that needed some action. 98% of these patients that tested negative did not recur through follow-up. And as I said, on those 12 patients, there was a change in the management of those patients that prompted some earlier intervention rather than waiting. I believe the lead time on this cohort was about 5.5 months, if I recall correctly. And that comes with the concept, but usually a question about what do you do with a patient that you're signature positive and you don't have any clear evidence in imaging about where the recurrence could be. And when you review this hard and you go into dissecting every case, I don't, and this is an opinion that might not be supported by Natera, but I don't think there's usually a true no evidence of disease on imaging. There's always that small 3-4 millimeter nodule that probably you're gonna be, let's follow it up with imaging in 6 months, or that lymph node that is very borderline, 8 millimeters, 9 millimeters, that is not positive by imaging that it's bothering you, and you as a surgeon, it's like that lymph node is bothering me, and that's where you end up biopsying and it comes back positive. So I
Yeah.
think it pushes you to act a little earlier rather than have a more observation approach in those patients.
Yep.
Next slide, please. So then this was a bigger cohort to try to include also stage 3 patients that were resectable. The idea was surgery, have a 3-month period to obtain ctDNA, and try to follow those patients after adjuvant therapy as well. We can see on the Kaplan-Meiers, we can go to the next one, how there's still a benefit that is maintained there. Patients that remain negative are going to remain negative throughout time, and actually is a very prognostic factor. Even before having these patients any adjuvant therapy, if they were negative, is a good um, um, predictive value of that. And we knew that the patients that were positive, they recur earlier. Their relapse-free survival and overall survival was definitely affected. And as I said, not only epidemiologically significant, it was clinically significant too.
One thing I'll add to this too, Dr. Tapias, is the previous data was based off of the exome test, and this data is based off of now the genome test. So I had mentioned, we're kind of always iterating to drive LOD down lower, limit of detection lower, getting negative predictive value better, improving sensitivity. And one of the big changes in the last year has been moving from a predominantly West-based approach in non-small cell lung cancer to a predominantly genome-based approach in non-small cell lung cancer. And this was the first data presentation using the genome test in that population. And again, I look at that overall survival. I mean, that's a single negative result in the MRD window predicts 100% overall survival out to 40 months. It's pretty good.
And this is what stages of patients?
This is 1 to 3.
To
Yeah.
3. Okay. And it looks like majority were ones.
Yeah.
Majority. Okay.
All right, let's I have a couple of studies, case studies just to show you these are real world cases. This is a 64-year-old male came with a 1.7 centimeter speculated nodule in the right upper lobe. Underwent a PET scan, showed that the nodule had an SUV max of 4.5. There was no metastatic lymphadenopathy. Underwent a robotic right upper lobectomy with lymphadenectomy with a final pathology showing an adenocarcinoma with PDL1 of 95% and the pathological stage of T1B and 0. He kept following up every 6 months. Can we go through the next slide, please? On the first scan, 6 months later, there was no evidence of recurrence. It was a completely clean scan. But on the second CT scan, there was a 6 millimeter nodule, as we can see in the imaging there, which probably some of us might think, oh, 6 millimeters. Let's just see a CT scan in three months and see what happens. But we obtain a signature at that point. And at that point, it was positive. That was the first test that we did in August. While the discussions were happening about what to do, we obtained a PET scan. The nodule was negative. And while discussing with interventional radiology and interventional pulmonology the best approach to biopsy that, we obtained another timeline for that signature that kept going up. So finally, was biopsy, came back as an adenocarcinoma. Patient opted to have SBRT for this lesion and became negative. Unfortunately, as I was reviewing this, the new signature came back and now became positive again. So he's in the process of getting additional testing at this point. So this is an example of how we can act a little earlier on these patients and continue a longitudinal follow-up with those testing and help us in addition to imaging.
Rising ctDNA, enlarged node, and negative PET.
Correct.
Interesting.
Yeah. So I was just going to ask you is like, are you at the point where you're so comfortable with this assay? Could you have just seen that scan and skipped the step of getting a biopsy? Because, it's so small, it was unlikely to show up on PET. Or just to do the PET to make sure there's no other disease. Would you ever consider just treating empirically because you have a positive ctDNA assay and you have a new nodule?
Yeah, that's a great question. So I would say that the PET will be still important to see if there's any disease somewhere else. I think that will really help. Now, the biopsy depends what you're going to do. I think as surgeons, this is something that we can approach with an operation and maybe wedge it out, and that's a discussion with the patient about doing that. Trying to have the radiation oncologist, at least in our institution, to try to do SBRT without tissue diagnosis is a little harder, and that will take some time. And actually, I appreciate that. Sometimes doing SBRT on things that don't have biopsies can get us into a gray zone that is not ideal. But I think this is very good information with the test to make me want to do something about that for sure. The second case is more of a case of, okay, what happens when things are negative and does it give me peace of mind when the test is negative? And this is a 70-year-old woman with a 1 centimeter left lower lobe lung nodule, PET positive, with an SUV of 2.7, underwent a left lower lobectomy. This was an adenocarcinoma, was papillary. At that point, it was measured as 1.5 centimeters. One of the perilobar lymph nodes was positive. All the metastatic lymph nodes were negative for a PT1B and 1 PDL1 30%. And she had an exon 19 deletion. She was started on OC by the oncologist. And we've been monitoring her ctDNA regularly, and it's been negative. And so far, there's really no evidence of disease on CT scan either. So in these patients that are a little bit more complex, that have maybe a higher chance of recurrence, it gives you an extra layer of, okay, things are going well. We'll see what happens when the OC is stopped, and we'll see what's going to happen with the ctDNA in that case.
So that'd be a great one just to put her back on, I think, if it starts to rise when that OSCE comes off. If it was like if I was the patient, that's what I'd want to do.
Yes.
100%. Yeah.
Exactly.
Yeah. And, I don't know if it was Natera's assay or not, but I recall seeing some secondary analysis from Adora that they
Yeah.
looked at ctDNA, and it usually found recurrence something like 5 months faster than you would have found it otherwise. I don't know. You may know the data better than I do, Dr. Krainock.
Yeah, I know the data that you're talking about. That unfortunately that particular analysis wasn't ours. But that idea is something that we're really, really interested in. Because like I said, especially when they've had such good DFS for so long on the drug, it's active and it's just suppressive. It's suppressing recurrences. It's oral and well tolerated. It's a chip shot. Just put them back on. And I think there will be patients that you'll save that way. I definitely believe that.
And then the last case is a stage 3A patient, 69-year-old, who's a post-resection, clear ctDNA postoperatively. Then during surveillance, the ctDNA turned positive. On imaging, there were some metastases to the mediastinal lymph nodes. This was reported with a lead time of 72 days. This is actually not my case. But then the patient received uh, chemotherapy and radiation, followed by durva, cleared the ctDNA again during treatment, and so far during follow-up, it's been recurrence-free. So, as I said, it helped us be a little bit more aggressive with investigating more, maybe starting treatments a little earlier, and also when it becomes negative, gives you an extra layer of peace of mind of going in the right direction.
Great. Well, we have a couple questions in the Q&A session. I think we'll start with those, and then I have a couple of questions as well. And certainly we can just discuss things as they come up. But the first question came in, which was, if you do a resection and your first ctDNA assay is positive, is it that you really didn't have a stage 1 case to begin with? So I think another way of phrasing that would be is, are we at the point of incorporating ctDNA
Yeah.
assays into our staging? Or do we think it's just sort of like, well, you just didn't do an adequate job with your imaging and you probably missed something? How would you interpret that?
Dr. Tapias, you want to go first?
Yes. So I would say yes. We have to assume that something is amiss, right? I think it's similar to with our pathological stage 1A patients, right? If you don't do a proper lymphadenectomy, you don't know if you really have a stage 1 lung cancer patient. So it's the same thing here. Something is amiss, something was left behind. We know that our operations are as good as they are still imperfect in certain ways. Our diagnostic tools are still imperfect in many ways, and I think this is making us dissect even deeper into what we need to do for those patients. There was probably a lymph node that was not found. There was something there's going to be something to explain. I think we have enough data now to show that there's going to be something. I don't recall right now, Dr. Krainock, maybe correct me. What's the false positive rate of the
Low.
test? But it's extremely low. It's
Yeah.
extremely.
It's low. I mean, we'll see false positives that will kind of, well, let me back up. We'll see quantitative values that are near limit of detection in patients that will float between positive and negative, right? Those are typically patients who are on suppressive therapy, right? So we'll see that. When you've got a whole number positive, right? Not a fraction, not 0.1, but like 1, 2, 3, 5, 10. That's very, very likely to be real molecular residual disease. I agree with the question asker that I don't think about those patients. I don't think about the TNM and the AJCC when I have a positive test in hand. Like if it's a positive test, it's full alarm. And I think you will, so let's say you do have a patient where, maybe because of histopathological features or patient preferences or whatever that wouldn't get adjuvant systemic therapy, although they're a candidate for it, both physiologically and within the standard of care, and you've got a positive test in hand, that's a great use case to be more aggressive and treat. You may not cure the patient, but they're definitely not cured now. And there will be a group of patients that you will cure. And so I agree with that idea that, I think we will see a day where molecular status is incorporated into TNMB. I guess it would be TNMBB, people are saying, right? For blood. But a positive test, regardless of staging, to me is, a very concerning finding and has to be addressed.
Yeah. I know I'm a member of the IASLC staging committee, and I know that there is active efforts if for the next iteration, which will be coming out 6 or so years from now, to include much more details than TNM. So to start looking at, for example, EGFR status, other things that are prognostic. But I think for sure it's coming that we're going to be looking at blood assays as part of that too. I wouldn't be surprised if it makes it into the next edition.
Yeah,
But
agreed.
that technology didn't exist before. So our TNM is our best estimate of
Yeah,
what we think the stage or the prognosis would be. And that's as good as we had.
yeah, absolutely.
There's another question, kind of a follow-up is, and this is a good one. It asks if the act of surgery manipulates and spills ctDNA, and if so, what's the optimal time to test? And I would say my own follow-up question to that as well is, um, I've heard some ideas tossed around out there that we ought to switch back to always taking our veins before we do our tumor manipulation in arteries, with the idea that we might be spilling more tumor as we're doing the lobectomy. Um, and I think there was even some effort to try to design a trial around this. But I was just curious what we know about this so far, and then more practically speaking, when after surgery should we test that we think whatever
Yeah.
spill we have would be out of the way and we could really get a sense of what's going on.
Well, the good thing about this is ctDNA has a really short half-life. So it's like 90 minutes, which
Oh,
is
90 minutes.
it's super
Okay.
advantageous for these use cases because your result is a snapshot in time of disease status at that draw, basically. Um, so anything you flush out in a circulation through tumor manipulation that's not representative of ongoing shedding disease remaining in the body should be cleared very soon after surgery. I think that the timing question is more about the physiological insult of surgery raising cell-free DNA in the background. So when cell-free DNA is high, it can interfere with test sensitivity. And so we say, 3 to 4 weeks post-op is kind of your window for your first test. Now, if you get one sooner, or even at that time, and the cell-free DNA is high, we'll just tell you, right? So we'll say the test is negative, but the cell-free DNA is high and recommend redraw. So I would say, 3 to 4 weeks after surgery is your sweet spot. That's mostly because of physiologic cell-free DNA and less because of tumor spill, because the half-life is very, very short.
Got it. Thank you. There's another question about what would be the recommended frequency of testing, and I think maybe we should send that to Dr. Tapias first, just from his own clinical trial experience.
Yeah, so the timeline is also something that needs to make sense for you using it. What we were doing, we were getting it at 3 weeks after in the first post-op to have an initial snapshot of what was going on, and then every 3 months with imaging for that study was every 3 months with CT scan at those 3 months to try to compare what was going on. What I do now is a little different. I don't do CT scans every 3 months, so I do them every six, and I get the first one at 3 weeks after surgery, and then get them every 6 months after that. Um, I get it earlier if I see something that I don't like. It prompts me to get that test a little earlier. And I'm trying to understand more and more what's going on with these patients after, like post-induction patients, how to follow them up. We don't have, at least personally, a lot of data on that, so we're trying to understand the test in that setting, and so far it's been very promising. So.
Have you so far, Dr. Tapias, had any circumstances where, let's say it's not a driver mutation patient, so it's not like someone who's on 3 years of alectinib or osimertinib, but maybe they were a stage 2A and they got 4 months of adjuvant platinum therapy, um, and you are following their ctDNA and it turns positive, nothing real obvious on scans. Have you yet encountered an oncologist who would reinitiate treatment without anything other than a ctDNA test, or is it just an indicator to go on a fishing expedition?
Yeah, no, not so far. And in our cohort of all those studies, we didn't, all of those patients, we didn't find any patient like that. I have to say that the initial problem when we started to use the test was to really have the oncologist kind of like believe in the data, because we didn't have much data in the lung, right? Now that we have this data, I think the oncologists are believing more the positive and negative results, and are helping order it and also guide treatment based on that. But a specific situation like the one you've described, I cannot recall facing a situation like that, at least in the lung. I don't know if Mike.
Yeah, there are people that do it. Um, the idea of treating on molecular recurrence in surveillance, we call it TOMR, TOMR, treating on molecular recurrence.
On molecular recurrence, TOMR.
Right.
Okay.
TOMR. Um, you know, super interesting place to study, and we are putting trials together that look at those questions. However, there's absolutely people that do it. Typically, oncologists that are prescribing systemic therapy. Typically, it's immunotherapy and good candidates for immunotherapy, or people with drivers that are, appropriate for targeted therapy. We haven't published these cases. I think what I'd like to do is probably a case series now, because there's, probably enough follow-up. But anecdotally, I can tell you is what I have seen, is, rising ctDNA, nothing on the scans, um, you know, high PD-L1 tumor in the history or driver in the history, puts the patient on, ctDNA goes back to zero, no overt recurrence. I've seen that happen for sure. Again, these are anecdotes. So we haven't published a case series of that, but to answer your question, do people do it? Yes, they do. From what I've seen, it appears to be promising in some patients for sure.
Yeah, I would say you have to just kind of like assume things, but we know with the data that it's quite prognostic, right? If you're positive, you're gonna recur at one point if you don't
Yeah.
do it. So sometimes trying to give more therapy and trying to make it negative makes a difference, 100%. Yeah.
Yeah. I just, I think that getting the patient to zero, it's so important. And so I think when the drugs are well tolerated, and you've got a fit patient who's a good candidate for immune checkpoint inhibitors or targeted therapies, that's the scenario where I've seen it used.
Um, Another question in the chat, which I also was wondering too, is Dr. Tapias, you were saying you have now switched to where you're doing your imaging and ctDNA on 6 month intervals, but do you stratify it like a stage 3A patient? Do you do more intense surveillance, or do you alternate ctDNA and imaging every 3 months or something like that? Like, do you adjust it based on this tumor stage?
Yes. So any post-induction patient gets scans every 3 months. Those get them every 3 months. Everybody else, stage ones or stage two, they get them every 6 months. ctDNA will go every 3 months on the post-induction cases. Yeah.
So your ctDNA and imaging are usually linked in a way.
Yeah.
Okay, got it.
Sure.
And then I had some other questions I thought might be interesting to bring up too. And I would encourage the audience members, please continue to send in your questions, and we'll try to make sure they get brought up. Just to be clear, this for lung cancer, it's any lung cancer. It could be squamous, it could be adenocarcinoma. What about carcinoids? small cell, like does any lung cancer get picked up, or is there any difference in the type of lung cancer?
No, I mean, well, you can design the test against any solid tumor. So
Okay.
as long as we can get tissue, we can give you back Signatera. Um, some types of cancer are more prodigious shedders than others. So like squames, they have high cell turnover. They're typically bigger. They have a larger necrotic fraction. They're very cellular. So they spill ctDNA a lot. Some adenos are fairly indolent, even though they're so deadly. They're not doing a lot, right? They took a long time to grow to what they are, and they're not doing a lot. They're not shedding a lot. Small cell, obviously, so aggressive. Neuroendocrine tumor, typically ctDNA is everywhere in those patients. Um, I've seen strong signal in carcinoid. Um, we have a few cases. I think actually some of the shorts were large cell neuroendocrine tumors. Um, so yeah, we can design against any solid tumor. I would say the test is applicable for any patient with lung cancer. When we don't have it in here, but when we did the genome testing on the initial patients, we enriched the cohort for the toughest patients to pick up, which is, teeny tiny stage 1A adenocarcinomas. And we actually picked up 9 of 9 recurrences in stage 1 adenos. So that's a good sign that even in indolent shedders, the test is performing better as we continue to iterate. But by and large, more aggressive, higher turnover, larger necrotic fraction, higher cellularity will all give more robust signal.
Got it.
But you can get it on. You can get it for any type of lung cancer.
And that kind of feeds into one of the other questions that just came up was, is it qualitative or is it more of a yes, no? Because like if you had a higher number, I know
Yeah.
Dr. Tapias showed some graphs of like some sort of some number that you get. Does that tell you about burden of disease, or is it more just that there's different tumor characteristics like you were just describing?
Yeah, I think if you draw, a line, um, and you look at things like number of nodal stations involved, size of the primary, the quantitative value will go up with, those findings. So it is correlated, but it's not like a 1-to-1, 100% thing. So it's not that straightforward to interpret in the sense that I can't tell you if you have this quantitative value, in this range, you're likely to have this number of lymph node stations versus if you're this number, you're more likely to have this number. Or if the tumor is this number of centimeters, it correlates to this range of MTMs. It's a little bit rougher of a correlation, but yes, if you, plot it all out and you look at correlation coefficients, it is a positive correlation with more aggressive features and findings, but it is not 1-to-1. One way to look at that is there's independent value of the test outside of what we already know about the tumor. We know bigger cancers, we know more necrotic cancers, we know more nodes involved are typically poor prognostic findings for the patient. But we don't always find that ctDNA is best fit to those things. And ctDNA, when you put it on multivariate analysis, always wins by a long shot. So even if you have very indolent findings on histopath and a positive ctDNA, it's kind of like back to the initial staging. That ctDNA it's the only thing, that matters at that point once it's positive. So yes, it's a rough correlation, but not a 1-to-1.
Got it. Okay. Um, let's see. There's another question about how long after your resection can you send the tissue? Like, could you send it from the path room, or does it need to be processed separately before it can be shipped over? Is there sort of a time window from the tumor coming out of the patient and when you can send it?
I think it can be sent at any time, right, Mike? We had patients that we resected 2 years before, and we still had the tissues, and they were sent for testing. So as long as there's a block and they can obtain tissue, they can create the assay.
Yeah.
Great.
Once it's in paraffin, we can work with it. I know we've designed against tumors that were over 10 years old.
Wow. Okay.
Yeah.
I was wondering too, like some future directions. I'm sure a lot of us as thoracic surgeons are in the business of seeing indeterminate pulmonary nodules. And
Yeah.
there's been such great interest in companion assays for lung cancer screening. Are we at all close to the point where this could be used as a companion in screening or again, as an alternate to imaging, that maybe you don't have to do the imaging quite as frequently?
Yeah, absolutely. I mean, as you can imagine, tissue-free approaches to MRD monitoring are hand in hand with early cancer detection technologies. Right? You're trying to diagnose and track cancer without tissue in hand. And so we're actively investing and working on solutions for early cancer detection and tissue-free monitoring. And specifically, yes, we're very interested in helping to clarify indeterminate pulmonary nodules either found incidentally or picked up in screening programs. And that's a place of active research in 2026 and beyond for us that we've been working on. So, we don't have a product right now, but it's on our roadmap. We know it's a need, and we're aggressively investing in filling that need.
Great. And then another thing I've certainly been curious about, I know that there is no pharmaceutical company who will sponsor this trial. It's something I think
So
about.
de-escalation, right?
Yes, I think about this in the NCI setting, in which I also spend some time, is, when can we start thinking about de-escalating, or instead of one size fits all, once you hit a certain stage that you get such and such therapy. Because I mean, to be totally frank, all of these trials where it's a year of adjuvant or
Yeah,
2 to 3 years is totally a number picked out of thin air.
yeah,
And once people started using that number, it became the standard, but it is based on no sort of biology or science.
yeah.
So what do you know about de-escalation trials and where we stand with that?
Yeah, we're working on a few different de-escalation studies. So actually, that's a great segue. I know we're going to run out of time, so I'll do this pretty quick. But we're super committed to FGen at Natera. We love to do it. It's really what we're passionate about. So we're launching prospective interventional studies. We love doing real-world observational readouts from people who are ordering. If those patients are among the audience, that would be something if you're interested in, we could talk about. And prospective non-interventional opportunities as well. So the signals are probably the most aggressive schemes we're working on. We're working on several. And these are studies that, we're going to manage and run, right? And these will be powered to clinical endpoints with sufficient numbers of patients to change practice, we think. And among the signals, there's key de-escalation questions that we're asking across histologies, including non-small cell lung cancer. So, in patients who get neoadjuvant chemoimmunotherapy, for example, who needs adjuvant consolidation immunotherapy? And does it need to be out to a year, or can it be stopped based off of negative ctDNAs? The other one would be exceptional responders in the metastatic setting who are on immunotherapy for years sometimes, depending on the practice patterns. When can we stop those patients as well? So both of those questions we're working on through the Signal trials. Bespoke is a real-world observational study. So this is commercial testing results returned to you. But there's a framework for ordering and testing and data collection such that we could do really nice observational data analysis. And then SCORE is sample collection for ongoing research and product evaluation. As I've said a couple times, we do a lot of R&D. We're always iterating and coming out with new stuff. And so the goal of SCORE is to generate prospective non-interventional data to support that assay design and development. Structured time points like Bespoke, but we're not returning real-time results. The goal of that blood is really for R&D internally. So those opportunities, are available now and will be in 2026 and beyond. And for de-escalation studies, yes, both resected disease and exceptional IO responders under the kind of Signal umbrella.
Great. Well, we're at the top of the hour, and so I was going to see Dr. Krainock and Dr. Tapias if you have any sort of final parting comments or closing comments before we hang up.
No, I would say that, one of the thing that we do as thoracic surgeons, we want to have a lot of control over the outcomes of our patients, and we want to be very successful and want to win the battle. I know, and I was one of them that had a lot of questions about what ctDNA would do for my practice, and we listened and we hear everywhere it's not ready for prime time. But I think we have enough data to at least make us curious about how that will help us to understand our patients and how to help them. And you will only know how it fits your practice if you start using it. That's the bottom line. We started without knowing in what direction to go, and we came out with a good group of people that help us understand the test better. So I encourage people to start using it. It will really help your patients a lot.
And I guess it just made me realize like one of the biggest areas we struggle is esophagus. And so is this being used in esophageal cancer so far? Because I feel like that's a very ripe area for this type of assay. Um, Dr. Krainock, any other closing comments?
No, thank you so much, Dr. Tapias and Dr. Martin, and STS. If anybody in the audience wants to talk more, I should have put my email on here. I don't think I did, but first initial, last name, so mkrainock@natera.com. Happy to set up follow-up meetings, talk about your patients, talk about incorporating it in your practice, talk about any kind of study you might be interested in participating in, or if it's your own IIT or one of our signal studies, or so reach out, keep the conversation going if you have interest or questions. And yeah, thank you for coming.
And thank you to Natera and to the STS for putting this together and for a great audience turnout tonight. Happy holidays, everybody.
Happy
Happy
holidays.
holidays.
Thank you.